Eggs are passed in feces in early segmentation. They have oval thin shells, about 60 by 40 micromillimeter. They develop and hatch in 20 to 48 hours, meaning 1 or 2 days, into rhabditiform first stage larva, which hatches and moves in soil. This is the diagram of the life cycle of ankylostoma. The adults here in the small intestine, the eggs pass out, then the first stage larva develops here, then this is the second stage larva, which, this is the third stage larva, the filariform larva, which is the infective stage, which penetrates the skin to establish infection. When it comes into the body, it passes with circulation to the lungs, and from the lungs they make what does Ascaris lumbricoides. They penetrate the alveoli, pass on the bronchial tree to reach the pharynx. From the pharynx, they go down into the esophagus, the stomach, and then the duodenum as fourth stage larva to establish another infection. The larvae develop and molt in soil for 1 week to reach the infective larva. Also, another comment that the infective filariform larvae don't feed. They are attracted to the human skin by human sweat and excrete on the skin. The ankylostoma larvae can also infect humans through the buccal mucosa, through milk, and transplacental during larval migration in the mother's circulation. After penetration, the larvae pass with circulation to the lungs, then break into alveoli, molt, and pass through bronchial tree to the larynx, pharynx, esophagus, and finally reach the duodenum to grow into adult. This is the egg of ankylostoma, and this is the male posterior end with widened bursa. Here is the male bursa supported by cuticular thickenings. We call them rays. Another comment on the infection of ankylostoma, that it penetrates in between the toes in the feet, and also if anyone is working with infected mud, like those who make pottery or العمال بتوع الفخار مثلا, they can have the infection from the soil. This is the other type, or the second type of hookworms, which is Necator americanus. They call it Americanus even if so, the origin of this worm is Central Africa. It is called the New World hookworm because it firstly was recorded in America, but there it is introduced there from tropical Africa, as we say, during the slavery trade. Morphology and life cycle. The adults are similar in shape to Ankylostoma duodenale, but they are smaller in size. The head is sharply bent backwards more than Ankylostoma. buccal capsule is armed with cutting plates instead of teeth. This is the difference in morphology, and the male bursa is also different from that of ankylostoma male bursa. The eggs are larger than ankylostoma, being 70 by 40 micromillimeter. The life cycle is similar to ankylostoma, but the larvae infect humans only by skin penetration, not through the mucous membrane of the mouth. So, in case of ankylostoma, sometimes the Africans call the infection through the buccal cavity Wakana disease. This is a picture of Annecator americanus from the side view, and see how the buccal capsule is bent posteriorly, and this is, as we say before, this is the ventral side and this is the dorsal side. It is bent posteriorly to make a hook-like structure, so we call it hookworm. Here is an end-on picture. The uppermost part, the ventral one, here we can see these are the cutting plates instead of teeth. These are the subventral teeth here and here. This is called also the ventral groove. This enlargement may show you the cutting plates better. Pathogenesis of hookworms. Hookworm infection is closely related with anemia. يعني لما نقول hookworm infection على طول لازم نفكر في الأنيميا. Anemia is microcytic hypochromic type. It is caused by sucking and cutting into mucosa by teeth of ankylostoma or hookworms. Also, the anticoagulant effect of hookworm saliva, which continues after leaving the mucosal attachment site to another site. Adult ankylostoma sucks a part of mucosa inside its buccal capsule. الجزء ده من الميوكوزا لما بيجي in contact with the adult worm, and the cutting effect and the saliva which is secreted with anticoagulant elicits an immune reaction in this part. The inflammatory reaction which occurs may result in some fibrosis inside if it goes for a while, but usually the deprivation, the immune reaction can annoy the adult worm, so it can leave this part to go to another fresh part of intestine. So it leaves this part oozing blood because of the effect of anticoagulant and goes to suck blood from another part. This aggravates the bleeding from intestine and aggravates anemia. Also, there is iron store depletion because the blood which oozes out doesn't return again, or the hemoglobin is not absorbed again from the intestine. There is hyperplasia of the bone marrow towards the hemopoietic part, and also in heavy infection there is flattening and atrophy of villi, which occurs usually due to the effect of the sucking of mucosa. The patient, generally there is loss of weight, weakness, and mental retardation in young children because of the hypoxemia of the brain. Symptoms of hookworm disease. Earliest symptom is ground itch. Ground itch is a transient inflammation at the site of entry of the third stage larva. It is less common in Ankylostoma than in Necator americanus. Migration in the lung cause Loeffler syndrome only when it is heavy infection, but the light infection doesn't cause manifest Loeffler's pneumonia like that in Ascaris. Intestinal effect due to the inflammatory effect of the mucosa is usually nausea, discomfort, and in heavy infections, there are symptoms like duodenal ulcer. Eosinophilia is common and anemia is marked in chronic infection. There is severe pallor, striation, and spooning of nails, what we call koilonychia. Hemoglobin level may be as low as 4 grams per deciliter. This level may cause heart failure, and anemic heart failure is usual with chronic infection of ankylostoma or hookworm disease. Facial and peripheral edema can occur due to hypoproteinemia, which is with nutritional anemia. Pica is a phenomena which is called pica or mud eating. يعني الأطفال نبص نلاقيها تحك في الحيطان وتحاول تاكل فيها أو تاكل في الطين, which is related to hookworm disease. This can cause that the mud eating may induce hookworm disease because the children come in contact with mud. Also, it is caused by the disease because they have affinity to take minerals from the mud. Diagnosis of hookworm disease. Finding the characteristic eggs in stool analysis. The adult worm also can produce about 25,000 eggs per day. Iron deficiency anemia and eosinophilia. We also know that about 1 milli blood is taken by each adult worm per day. Sometimes the first stage rhabditiform larva can occur in stool, and we can see it in constipated patients. These are differentiated from strongyloides larva by having long buccal capsule between the oral opening and esophagus. Rough estimation of the number of worms can be done by what we call Stoll's egg counting technique, which will be discussed later in the methodology section. Here is also the picture of the egg, and this is the rhabditiform larva of Ankylostoma or hookworm. We see this part. This is what we call the buccal capsule, which is long here. This area is longer than that of strongyloides, and so we can, which this strongyloides, as we see later, it is usually giving larvae in stools. This is the larva of Strongyloides, but here we can differentiate between both. We can differentiate between them, inshallah, in the part of Strongyloides stercoralis infection. Treatment: mebendazole or Vermox is the first drug and it is the drug of choice. It is given twice daily for 3 days. Also, pyrantel pamoate is used in the same way as in ascaris. Correction of anemia by iron, which must be continued for 3 months after hemoglobin returns to normal. This to regain the depleted iron. A phenomenon related to ankylostoma is the cutaneous larva migrans, CLM, or what we call creeping eruption. Creeping eruption is caused by Ankylostoma caninum and Ankylostoma brasiliensis of dogs and cats. The larvae can penetrate human skin, but they don't enter the circulation, so they remain migrating in the subcutaneous tissue. They may cause severe reaction, forming hyperemic serpiginous tunnels. بيدي خطوط متعرجة كده لونها darker in color than the skin and it is inflamed and raised from the skin. There is pruritus, scratching, which leads to secondary infection usually. Endemic, this disease is endemic in the same areas with ankylostoma infection, usually in tropical America more than in other places. It is present especially in children. Treatment is by thiabendazole, which is absorbed from the intestine. It has good absorption from intestine and it is given orally twice daily for 5 days. Also, cryofreezing of the moving larva can cure the case. This is what we call here, this is the ordinary ground itch with acute inflammation after penetration of the ankylostoma larva, and this is the creeping eruption here. This is the creeping eruption. As we see, it is moving around in the foot. This is also creeping eruption near the face because this child eats mud. This is the buccal capsule of Ankylostoma caninum. We can see easily that there are 3 keys instead of 2 on each side. 1, 2, 3. This is Strongyloides stercoralis. Strongyloides stercoralis is the other. We don't call it hookworm because it doesn't have hooks, but it is from the family Strongylidae, and we call it stercoralis because it comes from mud also, or the infection comes from mud. It has the same distribution as hookworm disease, but its prevalence is less. It is a facultative parasite capable of completing free living life cycle in soil as well as parasitic life cycle with larvae in soil and adults in human. Morphology and life cycle. The free-living adults are 1 millimeter long, and under favorable conditions, they may have 2 to 3 free-living cycles. The digitiform larvae transform into filariform larvae, which can infect and penetrate human skin, sometimes if they find there is a human in their environment. Larvae migrate through the lungs and eventually they settle in the duodenum, same as in ankylostoma. The adult males stay on the mucosal surface and die early after fertilization of females, while the females are bigger, about 2 to 2.5 millimeter. They embed anterior part into the mucosa where they lay eggs, and the eggs readily hatch or rapidly hatch to rhabditiform larvae, which pass through the mucosa to the lumen and pass with stools outside the patient. The diagram of the life cycle shows the parasitic as well as the free-living life cycle. This is the free-living life cycle of strongyloides, with the male and female in the soil. They give eggs which give rhabditiform larva. Rhabditiform larva molts and transforms into adults. This is what we call the free-living life cycle. Rhabditiform larva, when transforms into filariform larva, it goes and penetrates human skin and makes the life cycle inside the human the same as in case of ankylostoma. Here, the filariform larvae enter the circulatory system and are transported to the lung, and then they penetrate the alveoli and are carried to the trachea, pharynx, swallowed to the esophagus and the duodenum, where they become adults. The adult female, as we say, penetrates the skin and gives the eggs. The eggs give rhabditiform larva again. The rhabditiform larva, either in soil, transforms into filariform larva and completes the life cycle again for the human. Also, it may transform into filariform larva inside the human body, and so the cycle is repeated by auto-infection, or it transforms into filariform larva in the mud and repeats the life cycle from outside the body. This auto-infection can result in hyperinfection the same way as in hymen lepis nana, but this is more dangerous than the infection with hymen lepis, which we discussed before. Larvae in the lumen may molt to the second stage rhabditiform larva and pass with stools outside to complete life cycle as free-living, or transform into infective filariform larvae. Some larvae may transform to filariform larvae within the intestine. They penetrate into the wall to the circulation to undergo migration till they come back to the intestine, which is called internal auto-infection. This is the rhabditiform larva as it comes in stool. Here we can see that This picture is for the larva, and we see here that the space between the buccal capsule, between the oral opening and the esophagus here is very short, and it is also demonstrated here in the slide or in the microscopic picture. And I said before that this is the difference between the rhabditiform larva of ankylostoma and the rhabditiform larva of strongyloides. It could be measured and known that what species is present in stool. Pathogenesis of strongyloides. On larval penetration, they may migrate in the skin for some time, what we call larva currents. Larva currents can occur in the skin of feet, in the skin of buttocks, in the skin where the patient gets in contact with the mud. Larvae in the lung cause Loeffler's pneumonia, which is prominent especially if there is repeated infection or internal auto-infection. And with heavy infection, the larvae cause patchy pneumonia, and the larva may be found in sputum, what we call verminous pneumonia. Adult females attached to the wall of the intestine, all the intestinal tract, but more present in the jejunum, causing intestinal irritation. This results in diarrhea, as we know. This is a picture of Strongyloides stercoralis, adult female, here embedded in the mucosa of small intestine, and we can notice the inflammatory reaction around by infiltration with mononuclear cells. This is also another picture of the rhabditiform larva, which is present in hyperinfection syndrome occurs with heavy intestinal infection and dissemination of larvae in many parenchymatous organs like liver, like kidney, like lungs, like brain. Sloughing of mucosa can occur, and inflammatory cell infiltration in the submucosa, granuloma formation around the larvae in organs like the liver or lung or brain. This occurs in immunocompromised patients more than in the immunocompetent ones. In immunocompromised patients also, it may affect the brain and cause coma to the patient. Eosinophilia occurs usually between 10 to 40%, but may be low in hyperinfection and also in immunocompromised patients, and there is usually increase in the immunoglobulin E, which is also low in case of immunocompromised patients. Now we come to the symptoms of Strongyloides stercoralis disease. First, we have ground itch. Ground itch occurs after larval penetration, and as we said before, it is more prominent in Strongyloides than in case of ankylostoma. Transient Loeffler's pneumonia occurs in larval migration, and in heavy infection the pneumonia is more, and larvae are seen in the blood-tinged sputum, what we call verminous pneumonia. Adult embedding in the intestine causes mild to severe chronic diarrhea. Sometimes they call it pea soup diarrhea، يعني شوربة البسلة، ودي بتبقى بتتعمل بإن البسلة بتتضرب في الخلاط مع الشوربة، فبتدي لون أخضر للفلويد أو للشوربة اللي احنا بناكلها، فعشان كده سموها pea soup diarrhea. Chronic diarrhea usually results in malabsorption syndrome. Correction of malnutrition causes clinical improvement of the case. Intestinal ulceration may occur and may cause melena or bleeding sometimes, or the symptoms like duodenal ulceration. In case of hyperinfection, this occurs with excessive larval penetration from intestine, internal autoinfection. There is involvement of lungs, intestine in this stage, and also in other parenchymatous organs. Patients become debilitated, severely ill, and may die as a result. In case of disseminated strongyloidiasis, this is occurring in immunocompromised patients where the larvae invade parenchymatous organs in addition to hyperinfection. The larvae invade the liver, heart, adrenals, pancreas, kidney, and central nervous system, and is a very serious condition. Diagnosis of strongyloides is easy by finding rhabditiform larvae in stools. If suspected to be ankylostoma larvae, they are cultured to obtain filariform larvae. Filariform larvae of strongyloides are totally different than those of ankylostoma. If the larvae are few, we concentrate samples by centrifugation. Also, we can do string test. String test means that there is some capsule which is swallowed and the cord attached to this capsule is measured as the length of the duodenum in a length that can reach the duodenum, and examination of duodenal contents when this capsule is full can help in diagnosis. In disseminated strongyloidiasis, the larvae can be found in sputum. In serological tests also can be used because the patient is debilitated and we can't do any biopsy anywhere. X-ray picture of chronic infection shows loss of mucosal pattern, rigidity, and tubular narrowing of intestine. This is also a picture of the rhabditiform larva. This is the characteristic picture of the filariform larva with bifid posterior end in an inverted V shape here. This is the characteristic feature of the posterior end of Strongyloides circularis, not present in case of ankylostoma, which has tapering in. Enlargement of the picture may show you the posterior end of strongyloides clearly. Treatment: thiopentazole is the drug of choice because it penetrates the mucosa and can affect the adult females. It is given twice daily for 2 days. Mebendazole twice daily for 4 days is less effective but more tolerable than thiopentazole in the debilitated patients. Also, we can give albendazole, which is well tolerated, but cure rate is about 85%. It is given daily for 3 days and repeated for 3 days after 2 weeks, and it can be used for hyperinfection syndrome, 400 milligram daily for 15 days. Ivermectin can be used daily for 2 days, also can affect the